when you think about medical imaging, there are some exams that feel familiar. Everyone knows what a chest x-ray looks like. We sort of get the grayscale of a CT scan. And then there's cardiac MRI. It has this reputation, doesn't it? It feels like, I don't know, the final boss level of radiology.
It absolutely does. And for good reason. You're trying to get this incredibly high-res picture of an organ that's twisting and squeezing and conducting electricity all at the same time. And it's sitting crooked in the chest. I mean, it's a moving target in every sense of the word.
Right. And it's not just the motion, it's the physics. I think a lot of people get intimidated because it feels like you need a PhD in quantum mechanics just to set up the sequences. But we're going to try and cut through that noise today. We're doing a deep dive into a really fantastic guide from Radiographics by Dr. Iman Munib and colleagues. It's called Routine Cardiac MRI, Systematic Approach to Interpretation.
And systematic is really the key word there. The goal of this deep dive isn't to turn you into a physicist. It's to look at Dr. Munib's framework, what they call the 4 pillars, and use that to turn what looks like chaos into a logical diagnostic story.
Okay, so let's start there. The paper argues that if you just start clicking through images, randomly, you're going to miss things. You need a system. What are these 4 pillars?
It's actually surprisingly intuitive when you break it down. Every scan you look at falls into one of 4 buckets: anatomy, function, tissue characterization, and hemodynamics. If you just keep those buckets in mind, you stop seeing a blur of pixels and you start answering specific questions. What's the structure? How's it pumping? What's the muscle actually made of? Is there scar tissue? Is there fat? And finally, how is the blood flowing?
So let's tackle that first bucket, anatomy. Because before we get to the flashy 3D movies of the heart beating, the author suggests starting with something much more static, the first look.
Yes, the preliminary assessment. Usually these are just axial images covering the whole chest, sort of like what you'd see on a CT. And this brings us right away to the first big fork in the road for cardiac MRI, the whole difference between dark blood and bright blood.
And this is something that really trips people up if they're coming from CT. In CT, blood is, it's gray, or it's white if you use contrast. But in MRI, we're actively manipulating the physics to make the blood look different depending on what we need to see. So why do we want dark blood for looking at anatomy?
Just think about contrast and boundaries. If you're trying to measure the thickness of the heart wall or look for a tumor or check the pericardium, you don't want bright white blood just washing out all the edges. You want the blood to be a black void so that the tissue, the myocardium, it just stands out really clearly against it.
So how do you actually do that? How do we tell the machine, hey, record the muscle, but just ignore the blood?
It's a technique called double inversion recovery, or double IR. And without getting too bogged down in the physics of it, just think of it as a timing trick. You send a magnetic pulse that prepares everything in that slice of the heart. Then you wait a very specific amount of time.
You're waiting for the blood to move.
Exactly. You're waiting for that tagged blood to flow out of the slice and for new, fresh blood to flow in. Then you snack the picture, and the new blood, because it hasn't been prepped, it gives no signal, so it just appears black. The muscle, which stayed put, gives a signal. It's basically a motion filter.
That's a great way to think about it. So on these dark blood images, Dr. Munib's guide suggests a few key sanity checks before we even look at the heart's function.
Right, because the blood is black, the anatomy is it's stark. So the first thing you check is the pericardium. That's the little sac around the heart. On these T1 or T2 weighted dark blood images, it should be a crisp, thin, black line.
And when you say thin, we're talking very specific numbers here, aren't we?
Oh, yeah. We're talking less than 4 millimeters. Usually it's more like 2 to 3. If it's thicker than that, or if it looks irregular, you have to start thinking about things like constrictive pericarditis. And if you give contrast and that thickened line lights up, well, now you're looking at active inflammation. It's a subtle finding, but it's incredibly easy to miss if you aren't looking for it on these first static images.
The guide also mentions checking the chamber size ratio here.
Yes, the RV to LV ratio. The right ventricle should always be smaller than the left ventricle. That ratio should be less than 1. So if you look at that axial slice and the RV looks just as big as the LV, that's an immediate red flag for right heart strain.
Which connects directly to the third check, which I thought was fascinating, the septal bowing. This feels like a physics lesson disguised as anatomy.
It really is. So the septum is the wall separating the left and right ventricles. Under normal conditions, the left ventricle is a really high pressure system. It has to pump blood to the entire body. The right ventricle is low pressure. It just has to pump next door to the lungs.
So that pressure difference pushes the wall to the right.
Exactly. The septum should be convex toward the right. It should look like the left ventricle is kind of bulging into the right.
But, and this is where the diagnostic punchline is, what if it's flat? Or what if it's bowing the other way?
If you see that that septum is flat, or worse, bowing into the left ventricle, the physics have reversed. It means the pressure in the right ventricle has spiked higher than the left. You've likely got pulmonary hypertension or some kind of massive right heart failure.
Wow, so you've just diagnosed a major hemodynamic crisis by looking at the curve of a single line.
Before you've even watched the heartbeat once.
Yeah.
That's the power of this systematic approach.
Okay, so we've checked the anatomy with dark blood. Now we need to move to that second pillar, function. But to see function, we need to see the heart moving. And to see it moving correctly, we have to solve the geometry problem.
The cricket heart problem.
Right. The heart just doesn't care about our body's axis. It sits at this double oblique angle in the chest. So if we just slice the patient like a loaf of bread, top to bottom, we get these weird tangential cuts that they're basically useless for measuring volume.
Exactly. You can't calculate an ejection fraction from some random diagonal slice. This is why cardiac MRI relies on what we call intrinsic planes. We have to build a new coordinate system that's based on the patient's own heart anatomy, not their chest wall.
Okay, this is the part that usually confuses people. It's a step-by-step process. Walk us through how you build these views.
It's a sequence. You use the initial scout images to find the heart. The first real diagnostic plane you build is the vertical long axis, or the two-chamber view. And you do that by drawing a line that goes strictly through the center of the mitral valve and the apex, the very tip of the heart.
So you're slicing the left heart vertically. You'll see the left atrium on top and the left ventricle on the bottom.
Correct. It looks like a little two-room house. Now, once you have that view locked in, you use that view to build the next one. You draw a line perpendicular to your two-chamber view, again making sure it passes through the mitral valve and the apex.
And that gives you the horizontal long axis or the four-chamber view.
The textbook view, this is the one everyone recognizes. You see both the left and right ventricle side by side and the atria sitting above them. This is your money view for comparing those chamber sizes we talked about. You can confirm that RV to LV ratio instantly in this view.
Now, the paper mentions a third long axis view, the three-chamber view. This feels a bit more unique to MRI and echo. What's that adding?
The three-chamber is special because it captures the inflow and the outflow in a single plane. The slice intersects the mitral valve, which is the inflow into the ventricle, and the aortic valve, which is the outflow from the ventricle.
So if you're looking for, say, a subaortic membrane or trying to see if blood is turbulent leaving the heart, this is the view you need.
Precisely. It connects all the plumbing. It shows you the blood entering and leaving the main pumping chamber in one continuous path.
Okay, we have our long axis. We've got the vertical, horizontal, and the inflow-outflow. But for the real volume measurements, for calculating that all-important ejection fraction, we need the bread loaf cuts, the short axis stack.
Right. This is the final step in setting up the geometry. Once you have your four-chamber view, you just slice perpendicular to it. Imagine slicing a baguette. You start at the base, near the valves, and you just slice, 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 all the way down to the apex.
And how many slices does that usually take?
Oh, depending on the size of the heart, you usually end up with somewhere between 10 and 18 slices.
And this is where that function pillar really shines compared to other ways of looking at the heart. Because unlike an echo, which often makes these geometric assumptions or uses a formula to kind of guess the volume, this stack of slices covers the entire ventricle.
That is a crucial point. In MRI, we aren't guessing the shape of the ventricle. We are summing up the volume slice by slice by slice. It's Simpson's rule. It's why MRI is the gold standard for volume and mass. There's no geometric modeling. It's pure data.
So we've set up our planes. We know where we're looking. Now let's talk about how we're looking. We said for anatomy, we use dark blood. But for these pumping movies, the cine images, we want bright blood.
Correct. For function, you want maximum contrast. You want the blood to shine bright white and the muscle to be dark gray so you can trace those edges perfectly as they move.
The paper throws a lot of acronyms around here. TrueFisp, Fiesta, Balanced FFE. It sounds a bit like a branding war.
It is exactly a branding war. It's Siemens, GE, Philips. But the generic term, and the one you should really remember, is SSFP, steady state free precession.
And why is SSFP the workhorse for these cardiac movies?
It just comes down to speed and signal. The heart is moving really fast. SSFP is incredibly fast, so we can get high frame rates. And it has a very, very high signal-to-noise ratio, or SNR. The images aren't grainy. They look like high-definition video. The contrast between the blood pool and the myocardium is stark, which makes Tracing those borders for volume calculations much, much easier.
However, and this is a big however in the paper, the authors flag a major Achilles heel for SSFP. It's sensitive,
It is extremely sensitive to magnetic field inhomogeneity.
which in plain English means metal just ruins it.
Exactly. If a patient has a sternal wire from a previous surgery or a surgical clip, or most critically, a pacemaker or an ICD, that SSFP sequence just falls apart. The metal distorts the local magnetic field.
And what does that look like on the image itself?
It looks like a black hole. You get these massive signal voids, these artifacts, that can literally obscure the entire heart. If you have a patient with a mechanical valve, an SSFP image might be completely unreadable. You just see a black blob where the heart should be.
So this is a very real-world scenario. You're at the console, the patient has a pacemaker, and your beautiful SSFP Stein comes up looking like garbage. What's the protocol? Do you just cancel the scan?
No, you change your tool. This is a key takeaway from Dr. Munib's guide. You switch to a different sequence called gradient echo, or GRE. Sometimes it's called flash.
What's the trade-off?
Yeah.
Because there's always a trade-off in MRI.
The picture is definitely going to look grainier. The SNR is lower. The contrast between the white blood and the gray muscle, it isn't as popping as it is with SSFP. It's an older technology, but it is stubborn.
Stubborn is good when you're dealing with interference.
Exactly. GRE relies on different physics.
Mm.
It uses a gradient reversal instead of a radiofrequency pulse to generate the echo, and that makes it much less sensitive to those field distortions from the metal.
So the artifact actually shrinks.
Significantly, you might still see a small dark spot right at the pacemaker lead, but that massive black hole just disappears. You can usually see the wall motion right next to the device using GRE, whereas on SSFP it would have been completely invisible.
That's a crucial tool to have in your back pocket. If the image looks terrible because of metal, don't just keep trying to fix the SSFP. Switch to GRE.
Exactly. It's the backup parachute. You hope you don't need it, but when you do, it saves the exam.
Okay, so let's recap where we are. We've covered anatomy using dark blood, we've covered function using bright blood SSFP, and we have our geometry set. The last piece of this systematic approach is communication. How do we tell the cardiologist where the problem is?
This is the Tower of Babel problem in cardiac medicine, right? If I'm a radiologist and I write in my report, there's a scar on the bottom wall, what does that even mean? Am I talking about the inferior wall, the posterior wall, near the apex?
And does the cardiologist reading that report interpret bottom the same way you do?
Probably not. And that ambiguity is dangerous when you're planning an intervention. So we use the 17-segment model.
This is the bullseye plot.
Yes, it's a standardized map that's used across all cardiac imaging, nuclear medicine, echo, and MRI. You visualize the left ventricle as a target or a bullseye.
Walk us through the rings of that target.
So the very center of the bullseye is the apex. That's segment 17, the very tip. Moving outward, the first ring is the apical territory. That's segments 13 through 16. The middle ring is the mid-cavity segments 7 through 12. And the outer ring is the base, up near the valves. That's segments 1 through 6.
It seems a little tedious to memorize all the numbers. Like, who wants to remember that segment 7 is mid-anterior? But the utility is just obvious.
It is absolutely vital, because if the MRI report says hypokinesis in segment 7 and 8, the interventional cardiologist knows immediately. Okay, that corresponds to the left anterior descending artery territory. They know exactly which vessel is likely blocked before they even go in with the catheter.
It creates a common language.
Yeah.
It aligns the way different specialties talk so everyone is looking at the same map.
Exactly. It completely removes the guesswork.
So, pulling this all together, Dr. Munib's guide really suggests that the complexity of cardiac MRI, that final boss feeling, is actually manageable if you just stick to the workflow.
It's a discipline. You don't just look at pictures. You follow the pillars. 1, confirm the anatomy and do your sanity checks with dark blood. 2, build your intrinsic planes so you're looking at the heart straight on. 3, assess function with bright blood SSFP and remember to switch to GRE if you see metal. And 4, map everything to that 17-segment model so your report actually makes sense to the person treating the patient.
It turns a physics problem into a checklist.
And that's how you get from a black box to a confident diagnosis.
There's one final thought I want to leave you with, something that really struck me reading this guide. We spend so much time looking at these static gray screens, and we talk about slicing the heart. But the physiology we're describing is just so incredibly dynamic. The fact that we can null the signal of blood just by timing a pulse to its velocity, it's mind-bending.
It really highlights that in MRI, we aren't just taking photographs. We are querying the tissue. We're asking the protons in the body to tell us their speed, their location, their chemical environment. And if you ask the question in the right way, using the right sequence, they give you an answer that can save a life.
It's math disguised as photography.
That's probably the best description I've ever heard.
Well, Dr. Munib and the team have done a great service with this guide. Hopefully the next time you see CMR on the schedule or just hear about it, that hesitation's a little less pronounced.
Just remember the 4 pillars.
Thanks for listening to this deep dive. We'll see you on the next one.